Well, it's 6:30, so it's probably about time to get started. Um, this morning, I was asked to present on behalf of the sea salt group a little about simulation, in particular mixed reality simulation as a teaching and research tool. So I have nothing to disclose. I live a very dull life. I don't have anything that interesting going on in my world. This morning, I'm thinking we're going to talk a little about about this new simulator that we've just put together for blocks in the pterygopalatine fossa, and then use that as sort of a jumping off point to discuss the simulator system that it's built on, and explore its potential for other tools to be developed by other people. So in terms of why do we use simulation? At this point in history, we're at a place where we see over 400,000 deaths a year that are attributed to medical errors. And about 3.5 million people a year in the US are injured by medical errors. And this is not really a new thing. It's sort of a product, arguably a product of the way graduate medical education is executed. Medical education and graduate medical education residency in particular, essentially for the last 100 years, have functioned on a model of apprenticeship that we bring residents into an environment where seasoned physicians are working, and we sort of invite them to work with us in patient care. And it's through working with us in patient care that they are trained. And I wouldn't say that this is necessarily a bad model, but it hasn't really shifted much in a very long time. And despite the fact that technology has evolved to a degree to allow us to use other models to probably not replace, but perhaps supplement this apprenticeship kind of education. Simulation really isn't a new idea, certainly not in healthcare. Clay models have been found all over the globe that were used for, we think, teaching anatomy or anatomic pathology that perhaps training physicians or experienced physicians didn't encounter very often. And they're kind of neat to look at. You know, this was a model that was found in the Middle East of presumably abdominal contents. And here's another one that's much more clearly abdominal contents that was found in North Africa. And another one that clearly is intestines. This one was found in Central Asia. So this is the sort of thing that humanity has been modeling, probably to try and understand how things are built, or so that early surgeons could have the opportunity to sort of feel what is this thing, what are these pieces likely to feel like when you actually encounter them in the real world. And then what we would think of as a more modern simulator or a task trainer is also not super new. The first one was developed in the 18th century in France as a simulator for delivery. Delivery, even now in some parts of the world, carries high risk for both mom and baby, and infant mortality and maternal mortality associated with delivery was high. In an attempt to try and approach that in a way that would train people to better be able to manage this situation and hopefully decrease that mortality, this simulator was built from a human pelvis and a dead baby to allow simulation of birth. And the little bit that I've been able to find suggests that it actually was helpful. I'm not really sure how that was measured because I can't find data, but you know, a paper from the 1700s is not easy to hunt down to begin with. But things have sort of evolved, and now we're in a place where the models that we're using for teaching, the simulators that we're using for teaching, are capable of being much more than just a clay impression of what does somebody's insides look like, or a couple of pieces of anatomy, so we can demonstrate how they interact. And now with the advent of a lot of computer technology, we have the ability to explore things like what are called mixed reality or augmented reality, which essentially is taking technology to mirror virtual objects, things that only exist inside computer programming, and the physical world, and through some sort of display, whether that's a computer screen or a head-mounted display or a cell phone screen, being able to marry these two pieces of information and have them interact or not interact, sort of depending on how the programming is built. And that's sort of whether the degree to which they interact is what separates mixed reality from augmented reality. For the purpose of this talk, the terminology really doesn't matter a lot. But what we're talking about is simulation tools that can allow us to explore a physical object that doesn't have to contain 100% of the physical elements we might want to play with in terms of simulation, that we can build some of that just into a computer exercise. Simulation here at UF is not really a new thing. The human patient simulator that's sort of affectionately known as STAN over in the Sim Center was developed here back in 1985 with J.S. Gravenstein and his team. So we've been, as an organization, playing in this pond for quite some time. More recently, we've developed this platform called the System of Modular Mixed and Augmented Reality Tracking Simulators that is becoming a hub for a series of simulation tools that is all built around one core piece of technology that at the concept level is akin to the stealth navigation systems that are used in the OR by our neurosurgery and ENT colleagues to track instruments while they're operating on a projection of a specially formatted CT. So what this system essentially does is it's at its very basic level, it's capable of tracking, magnetically tracking different instruments that we might be using as part of a simulation exercise and how they interact virtually with a physical model. So for instance, we could pick up a virtual ultrasound probe and stick it on a gel block that represents a piece of tissue. And inside that piece of tissue, there might be physical bones that are 3D printed, for example. And there may also be virtual soft tissue. And the computer's hardware and software is capable of tracking where are things like that ultrasound probe, or perhaps a needle, or the camera view, the position that you would be using to look into this simulation. Where are all these things in the 3D world, and how do they interact with each other, and how can you make this physical needle or this physical ultrasound probe interact with virtual soft tissue? So the newest of these is this simulator that the CSALT team and I have developed over the last year or so, a year and a half, I guess, at this point, to simulate and teach the blocks in the pterygopalatine fossa. So essentially the way this one is built, we have a 3D printed skull that is then embedded in this silicone gel. And then inside the computer, we have virtual, both hard and soft tissue. So it's able to track this needle. It can tell us if we poke the needle in here, you can run into the bone with the needle. You can feel that physically. The computer is also capable of telling you which bone did you hit. The soft tissue, the muscles and the nervous structures of interest are also all in there. So the computer can tell you, did you actually end up putting the needle in the correct place? And if whether you're in the right place or not, how far were you from sort of a perfect position? This little black screen in the corner here is a virtual ultrasound element. So you can put a virtual ultrasound probe in here, and it will give you a simulated image of what would an ultrasound picture look like based on the position and the angling of the probe. So really, we can start to explore this block both for training purposes and for research purposes in a way that doesn't have to put a patient at the sharp end of the needle. So why did we bother with this? We found over the last 4 or 5 years with the APS group that these blocks have become very much in demand and have become one of the things that we are doing more than anything else. Since 2016, when I placed the first of these, we have now placed over 1,500 of these blocks. So we're doing about 300 a year, 300 patients a year. And we haven't really had any safety problems with them. Probably the most serious thing that we've had is a little bit of skin bleeding where the needle goes in. And there's nothing surprising about that. When you poke somebody with a needle, it's sort of expected that there's likely to be a little bit of blood where you put the needle. But we have not encountered any serious issues with these. Nonetheless, when you're learning to do this kind of thing, trying to learn to put a needle at somebody's skull base, in particular, if you're trying to learn to do this in young children, the process of learning to do this is intimidating. So if we can get to a place where we can start to teach people at least the mechanics and some of the anatomy without having to introduce that intimidation factor, that seems like something that would be a worthwhile exercise. So as demand for these blocks continue to grow, we're really thinking that this is a tool that can be used to teach some of the skills without really having to induce the sort of stress that's associated with, you haven't done this before, you've had maybe a brief lecture about the anatomy, or you've read some about the anatomy, and now you're in the operating room and somebody is instructing you hands-on how to place this needle in another human being, and there is that sort of natural concern that you could hurt somebody. So I think this is a great tool to be able to introduce this kind of thing without having to make it as stressful as it has been historically. And this is sort of a unique system in medical education. While simulators are not unique, the vast majority of simulators that exist are diagnostic simulators. So for instance, one of the earlier electronic simulators was a tool called Harvey that essentially generates artificial heart sounds. And residents or medical students can put on an earpiece that sort of mimics a stethoscope, and the simulator, by placing a stethoscope on a specific stethoscope for the simulator on different places on the chest, it can generate heart sounds that you would be able to appreciate from that location. And it's capable of mimicking a whole variety of normal and pathological heart sounds, and really is a very helpful tool for the cardiology world in terms of learning to interpret heart sounds. But it's a diagnostic tool. It doesn't help you with any sort of interventional thing. So if you can appreciate heart sounds that suggest to you this patient may have a pericardial effusion that is large enough, perhaps it needs draining, that simulator is not capable of letting you practice or learn how to do a pericardiocentesis. All it can do is present the heart sounds. And we have, other simulators at our disposal that are capable of a little more, like STAN or some of the other what are called high fidelity patient simulators that are over in the sim lab. So you can go over there and you can get the machine to demonstrate a set of pathology, and you can essentially instruct the universe that you're going to administer a treatment or a set of drugs. And you can watch how the physiology responds to that. But even there, those things aren't really capable of intervention, not in the sense of a learner actually physically doing something. You can't, for instance, place a chest tube in STAN. You could sort of say, hey, I think this guy has a large hemothorax, let's place a chest tube. And the simulation technicians and engineers can instruct the simulator system that you've placed a chest tube and now this big hemothorax drains, and you can see how his physiology responds, but you can't actually physically cut between the ribs and put this tube in place. Whereas these smart system simulators are both diagnostic and task training simulators. You can physically do things to them and learn how to do the physical task. And that is sort of unique in the simulation world and in the medical education world. The head is not the only one. There are several other tools in this family that currently exist or are in various stages of development that include some blocks here for regional anesthesia in the chest, in the thorax. In particular, this is looking primarily at epidurals and paravertebral blocks and intercostal blocks. If we start over at the other end here, this is an IV trainer that is in development that would be capable of letting us do both relatively superficial in the hand and relatively deep IVs in the forearm with and without ultrasound guidance. This one here is this sort of hemithorax, I guess, is a tool for training in central line placement. Both internal jugular and subclavian central lines can be taught with this machine. And this block now is essentially standard curriculum for all of the anesthesia, surgery, and internal medicine residents as they're starting here. Before they can place central lines in real patients, they have to demonstrate competency on this simulator. This other head is a ventriculostomy simulator. So this one can let the neurosurgery residents practice placing EVDs without having to put a real patient's head in harm's way. And this mysterious looking thing is a trainer that's under development for urologists to perform ultrasound guided prostate biopsies. So there's a whole range of tools that are available, and we can see that all of them have this same sort of pattern built into the bottom that allows them to snap into this one unit here that essentially is the tracking hardware. And then in the computer, you can see this one is what's hooked up now is the prostate trainer. So you can get a virtual ultrasound image and you can see a 3D representation of the prostate and how a needle interacts with the prostate. So this sort of allows, with this one in particular, people to learn essentially how does 2D ultrasound represent 3D tissue, and how can you use the information from a 2D ultrasound to more reliably sample the vast majority of prostate tissue when you're taking a prostate biopsy, rather than accidentally ending up with a more limited sample, largely because while the technique and what you're trying to accomplish is very familiar to a urologist, they spend less time interacting with ultrasound, and being able to reconstruct the 3D anatomy from a series of 2D images is probably a more difficult task to learn if you don't do it that often. So what are these things capable of? All of them are capable of, basically we have three tools that are built into all of them: a virtual ultrasound probe, a virtual needle, and a tool for positioning the external camera to generate the view of the 3D anatomy that you would like to see. All of these tools are tracked with what the engineering world calls 6 degrees of freedom. So it is capable of tracking basically the movement of this tool in every direction that you could move it, towards or away from the simulator, to the left, to the right, up, down, changing the angle. In the virtual world, they're capable of generating virtual anatomy. So in this case, this circle could represent a blood vessel, for instance, and perhaps a subclavian artery or a subclavian vein. And you can use your ultrasound probe to obtain the image you might like to try and cannulate this vessel, and then you can introduce the needle and direct the needle towards the vessel the same way you could under real-time ultrasound guidance. And the machine will respond appropriately. It'll tell you if you put the needle in the wrong place, for instance. So this is some imaging from the central line simulator, and we can see that this ultrasound probe is in place here. We've made the skin and muscle transparent so we can see the anatomy underneath. The bony anatomy is here virtually. It's also printed into the physical model. This red square here represents the incination plane. So where actually is the ultrasound beam, and how can we see how that interacts with the 3D anatomy? The purple obviously are the veins, the red are the arteries. We've got lung here, we've got a thyroid here. On our virtual ultrasound image, we can see our internal jugular vein and our carotid. The needle here is being advanced. We can see our needle tip in the internal jugular. We can see virtually here the needle is in the correct vessel. So this is a great way to teach people how to do things where there's some risk involved to a patient without having to actually put that patient at risk. This is some imaging from the thoracic simulator. So we can see here that our ultrasound beam is slicing through this superior costotransverse ligament, through our transverse process, through our rib, lungs we've got underneath. And we can see on the virtual ultrasound that we've got lung imaged here, we've got our superior costotransverse ligament, we've got our transverse process, we've got the rib just sort of sticking out from underneath the transverse process a little. And this could be used to teach thoracic paravertebral blocks, or to practice thoracic paravertebral blocks. This can also be used to sort of explore the anatomy in ways that are harder using other techniques. So we can't really cut a patient open just to examine how do the transverse process and this rib interact, and how do those two interact with the lung? What sort of space is there? But this is all based on MRI and CT imaging from a real human being. So the data that's in here is representative of what the real world looks like. So we can use this as a research and exploration tool to see how is this anatomy built. And just because we have classical teaching about one way to do a technique, is that the best way? Or can we use this tool to explore different or unexplored ways to approach a technique? And can we find ways that are either easier to execute, safer to execute, or simpler, lower risk ways to approach the same sort of techniques? These simulators can also have built into them automated virtual tutors. So the simulator itself can teach people how to execute techniques. So in this case, this is sort of a subtask, a micro task about how to properly mark out some of the landmarks that are necessary for thoracic paravertebral blocks. And the simulator itself will walk you through what you should do, and it'll tell you when you get it right and when you don't. So this can be used in conceptually relatively austere environments to teach people that have you need a modicum of understanding. You need at least to understand what it is you're interacting with. But this can teach people that really are not experts how to do things that at the concept level are kind of complex. And virtual tutors like this can be built into any of the simulation blocks to have the simulator itself teach people how to do a technique. What they can't do is essentially do the technique for you. You still require a human operator at some level to interact with the thing. What they can't do yet, some of these that we are envisioning that this could be turned into not just a task trainer, but a patient care system, that this could be used, some of this technology could be used as real-time guidance for procedure performance in real patients, but we're not there yet. The tools still require a human interacting with them to be doing the technique of interest. And we don't have really the ability to take this and transition it to a patient quite yet. You know, it would be really nice if during some of those difficult epidurals, we had the ability to just slap a sensor on the patient and generate a 3D image of their anatomy and be able to watch where the needle was going, rather than dealing with the frustrating exercise of trying to get it where we know it needs to go when it just seems like their anatomy won't cooperate. There are also some size and mass constraints on these simulators. To date, we have built all of them with the hope that we can put all of the equipment in a big suitcase and it still weighs less than the 50-pound limit that airlines impose before they start charging extra fees. So that all of these can basically go in a big suitcase and we can take them anywhere. We have a couple of year history now of using the thoracic simulator at large regional anesthesia conferences for teaching and practice. The central line simulator has made its way to and from forward medical stations in Afghanistan a couple of times. So we've sort of demonstrated that these things absolutely can be shipped around the globe, and they can work well in environments as long as there's space to put it on a table and an electrical power supply for the equipment to run. But if you start to make them too big, then it gets difficult both for the pieces to interact with each other and to move them around the universe. We also haven't quite figured out how to make them do mundane tasks like cook or clean or do the dishes. So where could this go next? I think this really, the sky's the limit. And the question is, that I would put to you guys is, are there tasks that you think could benefit from being able to be done virtually like this? If you can imagine something where you think this kind of opportunity would be to benefit to faculty, to residents, to patients, to whoever, the CSALT group is probably capable of developing a simulator for that task. And if it interacts with, certainly if it interacts with an ultrasound and or a needle, this is definitely a task we could build with this system. And if it interacts with other tools, we could probably explore what options there are for developing those tools to work in conjunction with the simulation platform. Are there questions? Did I make any sense at all?
I have a question. This is Sam Lampatang. Could you go over the cognitive aids that are included in the presentation? I think it's one of your slides.
Yeah. So if we step back a little, this is probably the best picture, but the system is, because it's measuring the position of all of these tools in 3 dimensions, and it can tell you, is something tilted or is it twisted. This doesn't really have an image of the cognitive aid on it, but it is capable of telling you if you put an ultrasound probe on the surface, and what you're wanting is to have the ultrasound probe ultimately perpendicular to all planes. The system is capable of telling you, the operator, is your ultrasound twisted or is it tilted? And which direction do you need to move it to correct that? And where do you need to slide your probe, for instance? Which direction do you need to move it to optimize the image for the procedure you're trying to do? And this is a sort of an important piece of a lot of the integrated tutor kind of function, that people learning to do this.
That one is better. That one. Go back. Yeah,
This
go.
one?
Yeah.
Yeah. So this one really is.
No, go back one more. Sorry. One more. That one.
So here, this image down here is able to tell you, in this transverse plane, what was the angle you're using for your needle to approach this vessel, and in the horizontal plane, what's the angle of your beam here? Do you have your ultrasound really perpendicular to the vessel? Do you have your needle entry at an appropriate angle? And this can help with things like learning what sort of risk are you applying. Could this image be optimized? I would argue yes. If this probe was, rather than sort of flat against the skin, if this probe was pointed straight at the floor, you could get an image here that had your vein lateral to the artery rather than overlapping by almost 50%. And that, in my opinion, makes cannulation of the internal jugular vein a safer procedure, because the likelihood of backwalling the vein and hitting the artery goes down. And tools like how to optimize your probe position are built into the system and can teach operators how to do that.
Yeah, and this is Sam again. I would like to comment that CAM's pterygopalatine fossa block was funded by IHAF, the development, and so was the thoracic paravertebral block to Boris Inatsenka, who then turned it into a grant from, I'm blanking out on the name of the foundation, the Regional Anesthesia Foundation.
ASRA funded it.
ASRA, sorry, yeah. So we have the technology, and there is a local funding source, which is not insignificant. And I believe this coming year, IHAF has a rotating yearly emphasis. Sometimes it's on basic science, other times it's on education. And I believe in 2021, it will be on education again. So two of the elements can be provided locally, which is the technology and the funding. What we need is the application, meaning the clinical application.
Any other questions or comments or anything anybody wants to talk about?
Dr. Smith, this is Holden. If a resident wanted to go utilize some of this training material, is there certain times that we can go over to? I assume it's over in the T-Salt lab.
So I think Sem is probably better equipped to answer that than I am. I think there, to the best of my understanding, is a bit of a booking process. So you sort of make an appointment.
Yes, so you can make an appointment, contact Tony De Steffens, and depending on what simulator you want to use, you could use it without any instructor, even as Cam already mentioned. Like the central venous access simulator, you don't need an instructor, which makes it easier to schedule. And that's also an important part of having the ability to run without an instructor. That was a hit definitely in Iraq, because there in an austere environment, the definition of austere can also mean no instructor, simply a tent and you and the simulator in the desert.
Thank you.
Dr. Smith.
Anything else?
Yeah, Dr. Smith, can you hear me?
You're kind of choppy, but I can hear you.
Okay, yeah, this is Durham. I'm going to see one residents. I was just wondering if you've ever thought about taking this platform sort of open source so that to create international partnerships for training in underdeveloped countries. It may be like a feasible model where you could utilize the system that you currently have, and you could find clinical application and training for residency programs and others, medical specialists who don't have access to this, by just providing the training toolbox. If they have an ultrasound, they can use the platform that you already have, and then partner with our department or university. And that may be a venue for clinical application and further development.
That's a great idea. Do you want to take it, Cam, or should I take it?
Yeah, we can go sort of back and forth, I guess. At the concept level, some of this is proprietary technology. So making it truly open access is probably not really going to happen. But it is what would be more appropriately called open source. So the software, what's called a software development kit, we would be happy to make available to people. And they can build their own simulators for whatever body parts they think they would like to do. There are pieces of how it works that we're not going to make sort of freely available so that people can just copy and make their own. But the tools to be able, for other people to be able to build their own simulators, stuff that we just haven't envisioned yet, yes, they are available. And what sort of cost is involved, I'm not sure.
Right. Yeah. So to elaborate on what Cam said, our system is described as open architecture, which I think is what the person who asked the question was looking at, but we're using the precise engineering words here. So open architecture means a third party can go and develop it, and they can actually build it anywhere in the world, and they can even run studies without paying the University of Florida anything. If they turn it into a commercial product, because part of the code is proprietary and patented, and also the hardware is patented, then they would have to pay the University of Florida a royalty. So it is open source. The SDK is it is not open source, sorry. Open source means 100% of the code is available. When I say the code, I mean the source level code. So because 5% of the code, the key ingredients, the secret sauce, is hidden behind what's called a dynamic link library. So the source code itself is not available. Then technically we cannot call our system open source, but it is open architecture because you can derive the benefits of the hidden source code from the dynamic link libraries. And the SDK is already available on GitHub, which is a well-known repository that's used worldwide. So to answer your question, it was a great question because we forgot to cover that. The system is available worldwide. I know some people in Denmark are already looking at it.
Any
And
other
I should
questions?
mention Tony Comeda got a publication out of this platform too. I just noticed Tony's on the line, and his manuscript just came out. And way back when Kaiser was chair, this was a strategy we had developed, which was that simulator development and research would become a platform for developing junior faculty careers.
If there's nothing else, I know the residents all have rooms to go and set up and make sure everything's ready for starts. So I won't hold anybody up. But if there are any more questions or anybody wants to discuss anything, I can hang around for a little bit longer.
All right, I think we should probably let the residents go to their rooms. Yeah.
Well, thanks very much, everybody.
Yeah. Thank you.